Upadhyay. And her mentor is Dr. Archana Shah. They are from AMC Medical College and LG Hospital, Ahmedabad. We are very much thankful for this program to our own President AOP Gujarat, Dr. Rakesh Desai, and our HSG AOP Gujarat, Dr. Kirit Sisodia. Dr. Yogesh Parikh sir is always there as project in charge and keep us energetic for the same program. Dr. Baldev Prajapati is the convener of this program, but sir is not available today because of some other prior commitment. I welcome Dr. Kirit Sisodia as he is there today with us. So Kirit bhai, would you like to say some words? Kirit bhai left. Okay, Prashant. Dr. Prashant Karya as a coordinator, he is one of us, me and Prashant. So would like to ask Prashant. Okay, so we are going ahead with the experts introduction. We have two renowned faculties as an expert today. One, Dr. Ritesh Shah. Ritesh sir has done the MBBS from BJMC Ahmedabad and MD from the VS Hospital. He has done his fellowship in pediatric neurology from Hinduja Hospital, Mumbai, and the fellowship in pediatric neurophysiology from Cleveland Clinic, USA. He is practicing since last 12 years and published many papers and presented also many papers in conferences. He has written many chapters in few books on the various topics, and he is a faculty for pediatric epilepsy training at various states and national conference. Welcome, Dr. Ritesh sir. We have another renowned faculty as an expert, Dr. Reenu Suthar ma'am. She is Associate Professor at Pediatric Neurology Unit in the Department of Pediatrics at Advanced Pediatrics Center, PGI Chandigarh. And she has done her MD and DM Pediatric Neurology both from the PGI. She has more than 125 publications in national and international journals and book chapters. She is the recipient of RCPCH Visiting Fellowship at Great Ormond Street Hospital, London, UK. She has travel fellowship in 2017 at AOCCN, and her area of interest is CNS infection, pediatric stroke, and pediatric neuromuscular disorder. We welcome very heartily, ma'am. So, as today Dr. Baldev sir is not there, the experts will guide the presentation and they will ask the question. So now, Sagrika, you can upload your presentation, and whenever after the case discussion, first from the history, then you will stop, and again then for the whenever the experts are telling, you can start the presentation and stop in between.
Okay.
All the best.
Ma'am, should I start?
Yes.
Good evening, everyone. I am presenting a case on CNS examination. I am Dr. Sagrika Upadhyay, third year resident in Department of Pediatrics, AMC MET Medical College, Ahmedabad. This presentation is under guidance of Dr. Archana N. Shah, Head of Unit in Department of Pediatrics, AMC MET Medical College, Ahmedabad. Now starting with history, Babu Hamza, 9-year-old male child born out of consanguineous marriage, residing at Khanpur, coming from lower socio-economic class, came to LG Hospital with complaint of delayed development and abnormal movement of body multiple times. Origin, duration, and progression. History started from birth events. In antenatal history, mother was having history of pregnancy-induced hypertension. No antenatal USG was done. Institutional delivery with full-term vaginal delivery, tried poorly at birth, but required no resuscitation and no NICU admission was there. Birth weight was 2.7 kg. Baby was with mother on breastfeeding. No event noted in postnatal period. At 2.5 months of age, patient had first episode of convulsion with fever within 24 hours of vaccination. Patient was started on some AED. MRI and EEG were done, suggested to be abnormal. At 4 years of age, AED was tapered and stopped. After 9 months, patient again had convulsion with fever. 5 to 6 episodes of fever-provoked convulsions since then, and each time dose of AED was adjusted. Last 2 episodes of convulsions were without fever, and latest being on the day of admission. Convulsion was in the form of uprolling of eyeball while in sleep, with fisting of both hands, with bluish discoloration of lips, frothing from mouth, involuntary passage of urine and stool. Episode lasted for 10 to 12 minutes, not subsided by some nasal spray, which was further subsided by some injectable medication given at VS hospital. Patient was unresponsive for 2 to 3 hours and brought to LG hospital by parents in rickshaw. He was sedated throughout the transport. No complaint of fever, trauma, vomiting, weight loss, and post-convulsion weakness of any limb. No complaint of recurrent respiratory tract infections or bowel bladder dysfunction to the patient. In family history, mother and father had second-degree consanguineous marriage. They have total 2 kids. The affected one is elder, which is 9-year-old, and younger one is 2-year-old. No family history of conversion, mental retardation, unexplained death, or tuberculosis. In feeding history, patient was only on breastfeeding till 1.5 years of age. Patient had difficulty in taking top feeds, more for solids than liquids. Liquid diet with the help of spoon was given with spillage at 1.5 years of age. At present, patient cannot feed himself properly. He requires assistance by mother. Patient is having no calorie and protein deficit. Developmental history. In gross motor, patient sits with support at 1.5 years, walks without support at 6 years, and not able to run. So developmental age of the patient is 15 months. In fine motor domain, patient helps in dressing and feeding, but cannot do it by himself. He needs assistance. So his developmental age is about 3 years. In language, he speaks only monosyllable at 8 years of age. So developmental age of the patient in language is about 6 months. In social, he recognizes mother. He is having stranger anxiety. He understands and follows simple commands, and he is having bowel and bladder control. He knows his gender. This has been achieved by 8 years of age. So the patient is having developmental age of 3 years. In each domain, the developmental quotient is obtained, and the DQ of the patient is 22%. And so the patient is having global developmental delay. In anthropometry, weight of the patient is within 70.
Can you stop?
Yes.
So history is over, no?
Yes.
Okay. So we'll discuss something over history and then we'll go ahead with examination.
Okay.
So Uh, can you just go on your previous slides?
This one.
Previous one. So can you summarize your history in 3, 4 important points?
Yes, sir. Sir, patient is having a complaint of involuntary movements
Hmm.
and delayed development.
Hmm.
Patient is having poorly cried at birth.
Hmm.
No significant antenatal care was taken by mother, and
Hmm.
patient uh, didn't admitted at NICU.
Hmm.
But he is having delayed milestone in each every domain,
Hmm.
and
Okay.
he is having a complaint of convulsions. First
Hmm.
started in the form of fever provoked convulsion precipitated by vaccination, but later on it was developed in the form of without fever in form of epilepsy.
Okay.
And parents is having a family history suggestive of second degree consanguineous marriage, which is significant, and
Hmm.
no family history of conversion.
Uh, so good afternoon, all. I just joined a little bit late. So Nishita, I just want to know about the perinatal details in a bit more description regarding. Can you tell me what were the signs of encephalopathy? What was the term, gestation, weight, and all, and how severe was the encephalopathy? How will you describe it? What are the markers that suggested it is a kind of a significant encephalopathy versus a where you expect that this may be responsible for his developmental delay and epilepsy and motor issues. Can you go on that detail again? Because I just could not hear, missed that slide.
Yes, ma'am. Ma'am, my patient is 9-year old.
ठीक है ठीक है
Yes,
Hello.
Sagrika, go ahead.
Ma'am, my patient is 9-year-old male child born out of second degree consanguineous marriage with institutional delivery, which was term delivery. Mother had history of pregnancy induced hypertension. Birth weight of the patient was 2.7 kg. He cried poorly after birth but didn't require any resuscitation management at birth. So not admitted in NICU and given to mother for breastfeeding, but patient developed conversion provoked by vaccination at 2.5 months of age, and then each and every time fever provoked conversion. MRI and EEG was done suggestive of some brain abnormality, and then patient developed the convulsions without fever, and to, the last episode was on the day of admission. Patient is having delayed development in each domain with partially vaccinated and normal growth pattern.
Okay. Okay. So can I ask you? Can we take here his questions regarding the history at this point of time, or we'll be discussing them later on?
Yes, ma'am. We will take the questions regarding history this point
Right.
of time only.
Right. Right. So, just can you tell me, this baby had a poor cry at birth, and there was no resuscitation, no NICU admission, and he was put on breastfeed. Okay. So, what are the subtle signs of encephalopathy which you should be aware about, that it could be significant, or uh, can you just enumerate what are the points? Since it was an institutional delivery,
Yes.
yeah, was there any documented Apgar score in this child?
No. Uh, uh, the danger signs of developing encephalopathy in a patient can be persistent cortical thumb, involuntary movements, uh, decreased decreased level of consciousness, feeding difficulties in the neonatal period, or abnormalities of any sleep problems. It can be danger signs, can indicate the developing encephalopathy.
No. I just want to ask, when you consider an encephalopathy in the neonate period is a quite a significant, because you told that this baby had a poor cry, but his transition was quite a smooth. He did not require resuscitation. He was
Yes,
on breastfed. So what are the signs and symptoms you should asking when there is no clear-cut history of quite a significant encephalopathy, which can go for towards a history of HI versus it could be some other uh, encephalopathy may be related to some other condition also. So what are the signs and symptoms in the neonate which points towards the diagnosis of hypoxic ischemic encephalopathy?
uh, ma'am, feeding difficulties in
Right, right. Okay, so
difficulty in taking breastfeeding.
right. So you have to tell us that when he was started accepting breastfeed. So
Yes, ma'am.
within first
Uh,
within first 30 minutes, hours, or it was a day, was any feed modification was given to the child?
no modification was given. Patient was taking breastfeeding.
Okay, okay.
And then term delivery was there,
Okay,
and
so though there was no resuscitation, no need of oxygen requirement, no tone changes,
no, no.
and he was breastfed
Yes, ma'am.
within first few hours itself.
Yes, ma'am.
Okay, okay, okay. So that's explained that the was, can you call this, though the Apgars and cord pH was not documented here,
Yes, ma'am.
right? Do you think it's a kind of a very significant encephalopathy here?
No, ma'am. Because ma'am, patient was had poor cry, but didn't require the resuscitation. No NICU admission, and was taking breastfeeding well.
Okay, okay. So then we go with the history of, again, subsequently, the child has a developmental delay, which is predominantly in the which sector? Though it's a global delay, but was there any difference between the
Yes,
each sectors?
ma'am. Predominantly in language domain. Uh, Fine motor and social domain is 30%, and
Okay,
language is up to 6 months, which is only 5% of
okay,
developmental
okay.
age.
And what about gross motor?
Gross motor is patient is 9-year-old and having a milestone of 15 months age.
Okay, okay. So he has got a significant affection of all the sectors, but it seems
Yes,
that his gross motor and language was the one,
yes.
has a severe kind of insult. Okay,
Yes.
okay. What about his feeding and all?
uh, Patient has a difficulty in taking solid food, but takes liquid diet with assistance of her mother, and with spillage of some liquid.
Liquid diet means like semi-solid, or he's on kind of assisted feeding with gavage, or
No, ma'am.
okay,
He can drink from a glass or cup, but with assistance.
okay, okay. Or, and one more question regarding seizures. Can you explain me the which are the seizure type? Polymorphic, or they are like monomorphic seizures, or they are like changing with this increasing age? And what are the current seizure type and current burden of the seizures?
Ma'am, first episode was fever provoked at 2.5 months, within 24 hours of taking vaccination. Uh, and then 5 to 6 times fever provoked episodes was there. It was GTCS type, but then Patient developed the conversion without fever, and 2 episodes of such unprovoked conversion were there. And last episode was generalized tonic clonic type involving both upper and lower limb.
Seizure burden.
Ma'am, he
Like
is
what is the
having
frequency and how frequent they are, like daily seizures, intermittent seizures, monthly?
once in every 6 months. He is having seizure. Last was in last year October, and present one was 1 month back.
Okay. Okay. So in addition, when we take a history of child who has a developmental delay, usually we also, along with these 4 sectors, we go on to vision and hearing and tone changes, its deformities. That also I want to know about in your history, whether you were asked about these points or.
Yes, ma'am. Patient was well, parents uh, got idea that the patient is not have achieved the milestone according to the age, and consulted to the pediatrician,
Right.
and then did MRI and EEG and got to know that patient has some brain abnormalities.
No, I'm asking vision, hearing, any kind of tone changes they feel. Uh, Feeding, you
Patient,
have told that he needs a modification of the
yes,
feeds.
feeding modification was required by the patient, and tone changes was there in both lower limb.
Mm-hmm.
Increased tone whenever the patient is agitated or angry or crying, uh, but patient has developed increased tone over the period of time in both lower limbs.
And what about vision and hearing?
Vision and hearing is adequate. Patient hears the commands, follows the commands given by mother, and uh, hearing is adequate according to mother.
Okay. 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 So now you go ahead with your clinical impression and how do you evaluate what are differential diagnosis?
Yes, ma'am. In general examination, in vitals, temperature is good, pulse volume is good. The temperature is normal, pulse volume is good, heart rate is within normal range, respiratory rate within normal range, blood pressure was within normal range. In my head to toe examination, patient is conscious and recognizes his mother and follows commands. No pallor, icterus, petechia, or any neurocutaneous markers. Drooling of saliva is present, and gum hypertrophy with malaligned teeth are present. This is a picture of a patient with having gum hypertrophy and malaligned teeth, and patient has abnormal adduction at hip joint in lower limb. Locked knee is present. CNS examination in higher mental function. Appearance, a patient is sitting comfortably on cot and he is calm. Both lower limbs were flexed at hip joint and knee joint. Conscious, GCS score is 15 by 15. A patient recognizes his mother, so oriented to person. Memory, attention, perception, insight, abstract thinking, and calculation are difficult to evaluate in this patient. Speech, he speaks only monosyllables with 5 to 7 words vocabulary, understands properly, and replies in gestures. In cranial nerve examination, olfactory, optic, oculomotor, trochlear, and abducent are within normal limits. Trigeminal are also within normal limits. Facial patient is having drooling of saliva, but bilateral symmetry of face is present. Uh, Vestibulocochlear nerve within normal limits. Glossopharyngeal and vagus. No any complaint of recurrent regurgitation or palate and uvula are normal with gag reflex present. In accessory spinal nerve, sternocleidomastoid and trapezius muscles are in normal bulk. Hypoglossal position of tongue is central with no fasciculation. Motor system. No any wasting of any muscle, so bulk is within normal limit. In power, patient is having 5/5 power in both upper limb, but 3/5 in bilateral hip flexor, extensor, adductor, abductor, knee flexor, extensor, ankle dorsiflexion, plantar flexion. Tone in the patient has a hypertonia and spasticity in both lower limb, both knee touching each other, both feet are plantar flexed in supine position. In deep tendon reflex, knee jerk bilaterally brisk, ankle jerk bilaterally brisk, biceps, triceps, and supinator reflex normal. Jaw jerk is absent. In superficial reflexes, corneal reflex is present, abdominal reflex is present, cremasteric reflex present, and plantar reflex bilateral extensor, which is Babinski sign present. Gait of the patient is diplegic gait, diplegic spastic gait with scissoring of both legs, adduction at hip, flexion at knee, plantar flexion of ankle. Patient is not having any abnormal involuntary movement. In sensory system, grossly within normal limit, because patient responds to stimuli, pain stimuli in patient is present. In cerebellar signs, grossly within normal limits, no any nystagmus, ataxia, or hypotonia. Patient maintains his balance by keeping both arms outstretched while walking, no sway to any side, and no signs of meningeal irritation is present. In other system examination, respiratory, cardiovascular, and para-abdominal systems are within grossly within normal limits. So diagnosis is a case of cerebral palsy, spastic diplegia with global developmental delay with a developmental quotient of 22% and epilepsy. Presented with convulsion in a 9-year-old male child born out of second-degree consanguineous marriage without significant perinatal event in a particularly partially vaccinated for age and nutritionally well child. Ma'am, I have completed.
Okay, so can we take some questions here?
Yes.
Okay, so Garika, can you tell me about anthropometry of this child?
Ma'am, anthropometry, patient is having
Did
no.
you show that slide?
Yes, ma'am.
Okay. Yeah. Okay. So you said this head circumference is 47 centimeter.
Yes, ma'am.
That is between 50th to 90th centile. Okay.
Yes.
Okay. Now next question is regarding the optic nerve examination in this child. You just said that watch is mobile. I think that's not sufficient. I think you should be, as a PG resident, you should be knowing that what are the components of optic nerve examination, and you should be telling them in detail, because that's very important to know. No? Watch is
Yes.
mobile doesn't give you a good significance whether what kind of vision involvement could be there.
Yes.
Yeah, what are the things you look in when you do for an optic nerve examination?
In optic nerve examination, uh, ma'am, we can check visual acuity, field of vision, color vision, and fundus examination in the patient,
Mm-hmm. Pupillary reactions also.
and corneal pupillary reactions, direct, indirect light
Right,
reflex, and
right,
accommodation.
right. So you should be mentioning all these, although you may not be able to examine certain things because of the
Yes,
patient may be having intellectual issues and maybe not cooperative. But I think
yes,
it's important for everybody to know that these all things has to be
yes.
noted. Anything in the third, fourth, sixth? Was there any squint or malalignment?
No, ma'am, there is no visible squint. Both eyes are uh, alignment of eye is normal with normal uh, uh, symmetrical eye movements.
Okay, and then you said he has got a spasticities predominantly at the hip, knee, and
Hip,
ankle.
knee, and ankle.
Was there any involvement of upper limb?
No, ma'am.
Any subtle signs of weakness in the upper limb?
No, ma'am.
What is his hand preference?
Uh, tone of the muscles of upper limb is normal, no hypotonia. And
Mhm.
power is 5 by 5 in upper limb group of muscles.
Okay, okay. So hand preference is which side hand is preferentially using?
Sorry, ma'am.
Handedness, handedness.
A patient has no handedness. He picks up things with both hands.
Okay, so that is a quite a bit odd because by third and fourth year, handedness tend to be established in children. Even they have difficulties involvement, still they have a preferential use of one hand. I think you should ask the mother again and that what is his preferential hand because uh, he can hold a glass. You said he can hold a glass and
He can hold a glass, but
that,
with both the hands. He holds
both the hands. Okay. Okay, so now you can come to your the uh, database slides and tell me what differentials you will consider here.
uh, ma'am,
Hitesh sir, if you want to ask
different.
anything before
Yeah,
the differential diagnosis from the
right,
examination.
right.
Uh, so basically, madam has already discussed a lot of points. I just want to tell head circumference is 47.
Yeah, right.
So what do you think? Is it useful in your uh, like? Is it fitting with your any differentials? What do you think regarding head circumference? You are getting any information? Is it normal, micro, macro? What do you think? On how will you take it?
Sir, it is within a normal centile.
Is it
No microcephaly was there in the
okay?
patient,
Okay.
and uh, we take head circumference from occipital lobe to
Hmm.
frontal.
Occipital prominence to
Frontal prominence,
and sides?
above the eyebrows.
No, no, sideways. Temporal. Which area?
Uh,
Is there any serial head circumference available for this child?
no.
Can you hear me?
Yes, sir.
Hello. Yes. So, is there any previous head circumference reports or documentation is there?
No, sir. No such head circumference were taken in past.
She is at present 9 year
Yes, sir.
and head size is 47.
Yes, sir.
So it must be less than 50.
Right.
Do you have the chart?
Yes, sir.
Is there in on your PPT?
Not in the presentation.
Okay.
So, Sagarika, can you tell how it's the head circumference goes in the first few years of life?
Yes. Good
I think
question.
it's very, very important to know the significance of head circumference.
Because like in
Because,
neurology, you
yeah,
get lots of information from this head circumference, lots of differential. Your thought process will be different in different head sizes. So it is very important to go in detail of this.
Uh,
Just tell the physiological sizes and the rate of growth.
at birth in term baby, it is about 33 centimeter.
33 to 35. Yes, great.
33 to 35.
Yes, then
Then it increases and um,
increases at the rate of first 3 months, next 3 months, and next 6 months. Tell me the rates.
not able to recall. So,
Okay. So first 3 months is 2 centimeter per month. Okay. And next 3 months is 1 centimeter per month. And
yes,
next 6 months is 0.5 centimeter per month.
yes, sir.
So at 1 year, what is the head circumference? Around? It will be around how much?
If,
At 1 year. 6, 3, and 3. So 12 centimeter more than the birth. Okay.
yes, yes,
So 45 to 47 is the head size of a 1 year child.
yes,
So your child is 9 year with head size of 47.
yes.
So
so I think I think it's important to plot and know the Z scores. So that will give you a good information because
yes,
47 at 9 years is
plotting is very, very important.
definitely it's going to be a small or microcephaly.
Seems to be less than percentile. Needs
Yeah.
to be
But in
seems to
picture,
be less. I don't have chart.
yeah. But in the picture, it was not looking like a microcephalic child. What
Yes,
she had.
yes.
Yes.
So there is some discrepancy in head circumference, but I think that's very, very important for any neurological examination.
Because if head size is suppose 56 and
Yes.
suppose it is 45, then your differentials will be different. Okay.
Yes.
So I think very, very important. And you just make sure, because as madam is telling, in the picture, it looks like around like more than 50 or something. It is
Right.
not looking like 47. So
Yes.
just make sure. And next time, put it on the chart. Okay. So like we'll be able to see it properly. Okay. No problem. Go ahead.
Okay, so I have a question for you, Sagarika. So what are the two red flag signs or points in your this diagnosis which can take away your diagnosis away from a cerebral palsy? So what are these 2 points? Can you make out from this database of yours?
Ma'am, points not in favor of
Right.
uh, uh, not cried, no history of not cried immediately after birth. Patient was had having cry and no difficulty in taking breastfeeding after birth in a post neonatal period, and the conversion was initially fever provoked, and then it gradually become unprovoked.
So you just stop. So first is no encephalopathy. Is asking you two important points. The one is no encephalopathy. There is
Yes.
no encephalopathy at birth, according to your history. Okay. So that is
Yes.
one of the
Yes.
important points. Okay. Second
Yes.
point.
Yes, sir.
Second.
So
Second.
second point is that they have a history of consanguinity here.
Yes.
So
Yes.
so if you have this kind of history where you have an history suggestive HI, but there is no significant encephalopathy in the child,
Yes.
and if you have a history of consanguinity,
Yes,
then
and
you
you
have to go beyond cerebral palsy.
yes, ma'am.
Okay, and third point is that seizure in this child has started following a vaccination at 2.5
Yes,
months of age, and
yes,
fewer
yes,
febrile, and followed by he has afebrile seizures also.
yes, yes, ma'am.
Okay, so these are the points where you should think that the diagnosis may be beyond the cerebral palsy.
Yes, ma'am.
Okay. Okay, so shall we discuss some differential diagnosis, or we directly go for discussion of cerebral palsy in this case, Dr. Ritesh?
I just want to be little more clear, just for all the
Yeah.
and whatever was regarding developmental history. You told different areas and all this. What is like your interpretation of developmental history? You mentioned different points in all
Yes,
your domains.
yes,
So, is it delay? Is it regression? Is it delay more in one area? Is it slowly delayed? Water more, metal more? Just clarify all this.
sir, it was delay in achievement of each and every milestone. More,
There is no delay. There is no regression. Okay. There is no regression
there was no
of any
regression,
milestone.
no regression of any milestone.
No regression. Then which area is more affected?
The language is most affected, and then followed by gross motor, followed by social and fine motor.
The usual sequence in CP of your this
Usually, gross
range of
motor is major domain to be affected.
more delayed. Yes, yes. So here there is something is odd. Getting my
Yes,
point. So your
yes,
language is more delayed, your
yes,
motor is little bit delayed. So it is like mental delay is more than motor delay, which is unusual for your CP diagnosis.
yes, yes,
Okay.
yes,
Okay. So that is just I one point I have to make. So anytime you take the developmental history,
yes,
just
sir.
clarify these 3 points. One, whether it is really delayed, here it is delayed. Second, regression or delay, it is clear cut delay, no regression. And third is which domain is more, or it is globally delayed, equal in all fields. Because your differentials will be different in motor more than mental, mental more than motor, and global. Each three
Yes,
category has different differentials. Okay. So I think here, according to your developmental history, CP should not be the first word ideally, because
yes,
in CP the primary thing is motor deficit, which with associated problems with your global, with your epilepsy, with your vision, hearing. Madam has described it beautifully, all your points. So here there is some discrepancy in your history regarding CP diagnosis. Anyway, we'll take the discussion further, but I just want to make it clear that be very clear in your developmental history. Okay. Regarding your seizure history, I want to make one point. Many a times this we use the word very loosely, convulsion. So I just want to make it clear that use the word seizure, and convulsion is a manifestation, one of the manifestation of your seizure, like some motor movements. So whenever you're describing some events like staring, unresponsiveness, and all these things, they're actually not convulsions. They're just staring. This is a part of seizure. So use the word seizure, and during the description of seizure, you can use the word convulsion. Okay, just these 2 points I want to make in your chief complaints: developmental delay and some seizures. Okay.
yes.
You want to add something regarding basic points?
Yeah. Okay. So again, I've just told you that some of the red flags are there in your this diagnosis slide. So diagnosis should be like there would be other differential diagnosis more upfront in this child in comparison to cerebral palsy. And very rightly said by
Yes,
Dr.
yes, yes.
Ritesh that seizure has to be like described very well in semiology. So few points which I want to know when I take history of seizures is that like what are the habitual seizure, what are the frequency, when they do occur, sleep or awake or both, and then uh, what was the onset and who has seen the onset. I think it's very, very important because not every seizure is a generalized tonic-clonic seizure. What happens when the seizure is evolved and the parent sees movements or jerking, then they describe it's a generalized tonic-clonic seizure. But for the seizure has to be classified into focal, generalized, or unknown onset is based on the onset of seizure. So if somebody has not observed the onset, then it may not be good idea to classify that seizure into GTCS, because eventually all the seizures tend to progress and they become bilateral, engage bilateral networks and become tonic-clonic movement of both the limbs, upper as well as lower. So then the vital information about the onset usually misses. So if you just say that, but it's important to ask who has seen the seizures. It should be the first hand history. It should not be like described by third person.
Yes.
And if they had not seen the seizure during sleep, then it may be prudent to that you clarify at that point of time that the onset was not seen. Okay, so because the generalized seizures is used very specifically for few of the conditions only.
Yes.
Okay, so that point is very has to be considered whenever you take a history of seizure in these patients. Uh, and then some of the subtle seizures history may not be forthcoming, and you have to go back to the parents and ask them whether they have seen such kind of events. Either you can show some videos
Mm.
or you can enact yourself
Mm.
and have they observed such kind of witnessed these kind of seizures. So example is like epileptic spasm. Sometimes these are just ignored and they just taken as a startle. So you have to tell them whether they had these kind of seizures in the neonatal period. Other example is episodes of staring, as Dr. Hitesh has said. These are could be like sub absences. These like atypical absences could be coexisting. So so when we take a history, I think these are the some of the points which I want to know about the in the seizure history in detail to have a good idea whether we are dealing with the focal epilepsy, we are dealing with the generalized epilepsy, or still we are not sure about the type of seizures, because that has an implication for your diagnosis as well as for your management.
I think this very good discussion is going on. So just to summarize, if I want to have a diagnosis on the basis of your history,
Right.
then I have a four important points. One is developmental delay, where the mental is more than motor. I have a seizures, which is starting with febrile, prolonged febrile, then some unknown onset with little, not very much frequency because up to 9 years he has some 5, 6 seizures. So febrile plus afebrile, prolonged and short seizures with no encephalopathy at birth and some consanguinity. So my antenna will be high for underlying some genetic conditions with some epilepsy and developmental delay without examination. If I look at your history on, then in your examination there are 2 points like some microcephaly according to your size 47 is to me is microcephaly for 9-year child, but I think there is some discrepancy with some spasticity in lower limbs and any other positive point in examination apart from spasticity in wrist reflexes. Okay.
Gait abnormality.
Weight is
Spastic diplegic type of gait.
okay. Gait abnormality. Okay. So gait, but your child is non-ambulatory, I think, or ambulatory.
Ambulatory.
Okay.
Now regarding this term diplegia also I have a concern here.
Yes.
Now
Yes. Yes.
I asked you that what are the signs of upper limb involvement in this child. So
Yes.
then you just responded there's no tone changes, and
Yes.
but I think you should be looking for subtle signs of UMN signs. These are like pronated drift or rapid movements, rapid fine movements you can do and check that whether there is a truly upper limb. Because diplegia is a term when we use this when you have an upper limb as well as lower limb involvement. And usually diplegics have more upper limb involvement as compared to the lower limbs. And if you have only the gait issues and the spasticity is limited to the lower limbs, then paraplegia would be a better term. But you need to tell us extent of involvement. Like you said, there is some history suggestive of feeding, that he needs still a feed modification at 9 years of age. He
Yes.
still consumes semi-solid or liquid diet.
Yes.
And then you said there is no upper limb involvement suggestive of history. And so I think
Which is
extent of
odd.
involvement has to be like described in detail, that what are the areas in this child you seems has a issue with that because of tone and fine motor issues. So that has become a little discrepant. I think you can take this.
Yes. And, lower limb was only involved. Upper limb has no abnormality.
Okay.
But there is
And
a drooling.
drooling was there. Drooling
Yes.
was there. But facial asymmetry was not there. There was gum hypertrophy and malalignment of teeth. So probably because of that, patient had drooling.
No, don't just go for etiology here. You are just describing the findings. Okay, so we are not interested in etiology here. So uh, you have a drooling. What do you think the drooling is due to what in this patient? Where can you localize the drooling, or due to what are the different areas of the brain which can be involved, or which has damage that is causing drooling? Just tell me different areas or different axes which can cause drooling. You describe drooling under some cranial nerves.
Facial
So
facial nerve weak palsy can have a drooling of saliva or a liquid diet.
anything else? Just think over it. You know the CNS, you know the function of different areas, extrapyramidal, pyramidal, cranial nerves, you know everything, lower motor neuron. So where do you think the drooling comes from in this patient?
It can be due to excessive salivation or weakness of pharyngeal muscle, which lead to excessive saliva formation. Not able to, patient was not able to swallow the saliva.
So swallowing difficulty could be one cause of the saliva is coming out. If there is a normal secretion, he is not able to swallow, so it is coming out. So swallowing difficulty could be due to pseudobulbar involvement or whatever. So there is one possibility. Any other possibility of drooling? The etiology or localization of drooling could be due to some extrapyramidal involvement. Suppose there is some basal ganglia injury, whatever etiology may be. And can it cause drooling because of oromotor dystonia or something?
Yes.
There is another possibility. Swallowing difficulty is one possibility. Dystonia is another possibility. Any other possibility? So as madam has aptly said that there is a spasticity in lower limbs, there is a drooling, and you are telling upper limbs are absolutely normal. So it is not matching. There has to be some fine motor issues. There has to be some pronator drift, mild dystonia in upper limb, some weakness, or something, some less hand use. Something must be there. You just go ahead, examine the patient again, upper limb, try to give some toys and try to make some fine movements. You'll get some abnormality. I think so. Because it is very difficult to understand how it could be droolings and everything is present. Lower limbs are so much spastic with scissoring, and upper limbs is absolutely normal, which is difficult to explain. Okay. I think, madam, we can go ahead with little differentials and then treatment aspect.
Right. So tell us,
Hello.
Sagari, what will be your differential diagnosis in
Hello.
relation to hello?
Ma'am, hello.
Yes, please. You are audible to me.
Differential diagnosis to cerebral palsy can be any genetic syndromes which can lead to convulsions in the patient. It can be metabolic disorders or any which can lead to repeated convulsions, or any degenerative disorders of uh, like muscular dystrophies or any, but patient was having spasticity, not hypotonia. So patient can have ataxia any, due to cerebellar lesion uh, from the abnormality of gait.
Okay, so I would suggest you should go by like anatomical regions which you are getting in your history and examination of the brain, which you think they are affected. Like if this patient has got spasticity, which is definite in the lower limb according to you. So definitely he has got involvement of white matter, and he has got seizures. So definitely the cortical gray matter is also affected. And third, he has got some feeding issues, which may be related to his possibly white matter involvement, especially in the motor strip area, or there may be some plus minus dystonia or basal ganglia involvement. So you have a disease which is behaving like a static illness, where you said there is no evidence of degeneration here,
Yes, ma'am.
or regression is there. So a static disease which is affecting gray matter, white matter, as well as basal ganglia. So your disease should be localized to these areas. So differential diagnosis should come accordingly. So clinically, you did not find anything regarding cerebellar, as well as the LMN involvement was not visible here. So those would not be considered here. Okay,
Yes.
so some of the cerebral palsy mimics are important differential diagnosis here. So that you should always consider in the differential diagnosis. Okay, so in addition to cerebral palsy, we can consider differential diagnosis of channelopathies, Dravet syndrome in this child because of consanguineous history, no significant perinatal insults, seizure triggered by vaccination, followed by febrile prolonged status, and subsequently you have few afebrile seizures. The spectrum of Dravet can be variable from myoclonic seizure status to GFS, like febrile plus afebrile seizure. So definitely a sodium channelopathy would be considered here.
Yes.
Other differential would be to consider a metabolic disorder or IU infection, which can mimic uh, cerebral palsy. There may not be history of HI, but these kids can be affected in utero. So you can get spasticity, epilepsy, uh, all feeding issues, vision impairment. So that these are the some of the other differential diagnosis you should consider here.
Yes, ma'am.
Okay, and shall we take some investigations also, or we go directly to a discussion, Dr. Ritesh?
Investigation, we should discuss for 10 to 15 minutes. We have 1 hour still. So we can discuss 10 to 15 minutes investigation.
Ma'am, Ritesh sir may be having some
What is
difficulty in yes
the first
signal.
investigation of? Hello.
Yeah, you're
Yes,
audible.
sir. Please go ahead now.
So what is the first, like, what investigation you want to do to prove your means yourself that what you are dealing with?
Sir, MRI would be an investigation of choice in case of patient having multiple episode of conversion with spasticity in lower limbs.
Okay, good. So CT brain or MRI brain or MRI spine or what investigation?
MRI brain.
Okay. And do you think you need contrast here?
There was no signs of meningitis. Meningism was not involved, so not
So there
required.
is no any acute illness, no need. So
No.
I many a times why I asked the question, because many a times patient will do just MRI without any reason. So MRI is required, MRI brain. That's great. Okay. So like if we talk about this patient, is MRI done here?
MRI was done at the age of 4 months, but
4 months. Okay,
4 months.
it's too early. Okay. Okay. What was it?
Uh, there was some abnormality. No documents were available with the patient.
Do you have the report with you?
No, sir.
No report is available. Okay. So practically we don't have MRI report with us
No
or even
MRI.
pictures.
No even pictures. Patient parents were suggesting that the doctor explained like that some brain abnormality were there in MRI.
Okay. So madam, do you want to discuss about MRI further?
Okay, so Sagarika, what do you think that MR should be showing in such patients, as you have described children with the diplegic cerebral palsy, or what are the pointers in MR to suggest that it could be a sequelae to HI, or goes in favor of a diagnosis of spastic CP, and what are the abnormalities where you should be thinking more into it, like some other differential could be possible, how it's going to substantiate your further plan?
Ma'am, according to the history and examination, mostly the white matter would have involvement in MRI, like periventricular leukomalacia, which is the cause of diplegia, uh, and cortex can be involved because patient is having episodes of convulsion. Uh,
Okay, so you just told in the history you have told that he was a term baby with the history of
he was
delayed cry.
delayed
Okay,
cry.
so if you get this kind of history, what is the pattern in MRI you're going to see? A term baby who has an acute kind of ischemia without any antenatal or history of prematurity or chorioamnionitis in the mother. So what is the typical pattern you see in children who have a term and term asphyxia or term HI? What is the typical pattern which is seen in MRI? And what is the clinical presentation of these patients?
You're getting the madam's question.
Yes, yes, sir.
Okay. Just to help you to answer, you told PVL. PVL is common in which neonatal condition?
Preterm babies.
Preterm and sepsis.
Yes.
Okay. So as madam has told you, child is term without chorioamnionitis. So there is no sepsis, no prematurity. So PVL is unlikely here, according to your newborn. Okay.
So what are the MR signatures of acute and profound hypoxic injury? You have a different pattern in MRI according to the insult you have, like that will be different in a preterm neonate, that will be different in chronically hypoxic infant neonate, as well as different in a baby who has a partial prolonged hypoxia or acute hypoxic ischemic insult. So we can judge according to the MRI the event which the baby must have suffered, and even you can predict clinical phenotype correlation will also be there. So, so can you tell us what are the patterns we can see in MRI?
I don't know.
Okay. Okay, so typically, preterm babies with sepsis, chorioamnionitis usually have PVN, and they can have some evidence of IVH or germinal matrix hemorrhages. That will be in a preterm phenotype. Clinically, they will be more like spastic diplegic or spastic paraplegic. Uh, Acute severe hypoxic ischemic in a term baby, like what you have in your case, usually has a profound insult in what we call is thalamocapsular injury. Basically, there's a thalamus as well as basal ganglia. These are the area which takes a burnt, and usually these babies has a kind of a significant chorea dystonia uh, uh, phenotype. And the chronically hypoxic infant newborn, like if you have something like PPH and all, then you have more like encephalomalacia or profound loss of white matter, gray
Right.
matter, oliguria pattern. So
Yes.
this is how you can, with MRI help, you can tell us that this may be the responsible for etiology of this child, uh, cause of asphyxia or cause of significant perinatal insult in the child.
Yes.
What is the ideal age when you should have images in children with cerebral palsy? MRI, when we should do it?
Uh, at 3 to 5 year of age.
In neonatal period at 3 months, 6 months, 1 year, what do you think? 2 year?
Uh, at least few months after the episode of conversion.
Good. Good. So it is not related to conversion. Here, madam is asking in CP child, when you are suspecting, then should you get your first MRI done? What are the hurdles in getting the MRI done? Sagrika, can you hear me?
Yes, sir.
So what
Uh,
are the hurdles, scientific hurdles? I'm not asking about availability and cost.
sedation patients.
Yeah, sedation. So you need to give some anesthesia for the MRI. So I think, and you need to settle down the changes, inflammatory changes in costume. You will get it after a few months. So it is an individual choice, but as madam is asking, your answer should be, it should be after few months of birth, not immediately or in first 2 3 months.
Yes.
Okay, so what next investigation you want to do?
Ma'am, we can plan for EEG if at all MRI is not having any significant finding for complaint of multiple episodes of convulsion.
Okay, so EEG is warranted even if the MR may be normal or abnormal. So EEG has its own utility. It has its own value in terms of diagnosis of epilepsy as well as prognosis also. And then it will help you in classifying your seizure type also.
Yes, ma'am.
Okay, so EEG has to be done. What else you want to do here?
genetic testing for any. Uh,
No, I think before that you should be evaluating this child for comorbid conditions. That is, children with uh, even if it is your patient has cerebral palsy, then they should all be evaluated for vision and hearing issues. If you have additional comorbid problems of
yes.
feeding issues, they should be evaluated for oral motor dysfunction, GERs. Then
Uh,
regarding the
vowel,
tone,
vowel and letter.
contractures,
Yes.
yeah. So regarding his nutritional status, anemia, micronutrient deficiency, those all things has to be done.
Yes.
Now your workup for etiology will depend how your MR is going to show you changes. If you have an MR correlation, then the workup will proceed towards the comorbid problems this baby is having. And if your MR is not corroborating with your clinical history and all, which could be possible here, then you, along with management, you go towards the diagnosis of other conditions which can have a similar presentation as in your child. Okay. Uh, you can proceed with the discussion. We can take some discussion slides and then so any other points, Dr. Ritesh?
So I
Uh,
think she has not made further slides. I think this is the last slide.
Yes. Yes.
Yes. So now
okay,
we
okay,
have done with history. We have done with examination. We have
okay,
reached to
okay.
some clinical diagnosis. We have discussed about some MRIs, some EEGs. As Madam has told, if MRI is corroborating with your diagnosis, there is some intrauterine injury, or there is some you are getting some injuries, and you know that this is an acquired condition because of some insult. Then you go ahead with your comorbid condition screening, hearing, vision, contractures, all these things, feeding issues, and all. If MRI is absolutely normal, you are not getting any clue about your findings, then you go for genetic
Ye-
workup. So we have reached to this discussion. Now we'll go for management. So, like, what is your first, like, suppose this is your patient in front of you and you've done all these things. You get an MRI, you are getting some abnormality in MRI. Suppose there is some changes in MRI, and you are convinced that this MRI changes is responsible for patient's clinical problem. Now, what is your management strategy? How will you start your first thing, first conversation with your patient?
Sir, we have to give anti-epileptic to the patient. If a patient is having multiple episodes of conversion, the dose should be adjusted according to weight, yeah, every time as the child grows. And uh, for spasticity in lower limb, we have to advise patient to give physiotherapy to the patient. And uh, every day parents can also give uh, patient exercise at home, or he can bring to any physiotherapy center to the patient. Patient should be uh, have a pain relief if at all the patient is having any pain due to spasticity or contracture. uh, and patient should have ability to perform his normal day-to-day works by himself without much assistance of other. And for that, physiotherapy works. And for speech, uh, he can have speech therapy and um, behavioral therapy for such patient. If the patient has a very aggressive kind of behavior, behavioral therapy should be given. And for any contracture or any uh, joint abnormalities, orthopedic opinion can be taken. And for bowel and bladder dysfunction, uh, uh, patient should be trained to for his bowel and bladder routine. And patient should be given vaccination according to age, because such patient has a chance of getting infection more, and respiratory problems more commonly. And uh, GERD can be a problem in such patient. So parents advised to give feed in proper position, uh, with uh, no risk of regurgitation in the patient.
Okay, Sagarika, can you take this question regarding how will you manage spasticity in this patient? I think the main problem this baby is having is spasticity. I think main issues are feeding as well as language, cognition, as well as spasticity. So, what are the ways you can manage a spasticity?
We can manage it by routine physiotherapy.
Mm-hmm.
Um, we can give muscle relaxant to the patient. We can give even botulinum toxin in involved part to decrease the spasticity. We can give even intrathecal injection of baclofen or any such releasing agent.
Before going to drugs, after your physiotherapy, what is the one other important thing which you need to prescribe to such patients with spasticity? Uh, so your physiotherapy is the mainstay. It will remain forever, whatever you do with your child. Drugs, Botox, surgery, anything, plasters, physiotherapy will remain there for long time. So that is your main counseling. What is the second important thing after physiotherapy? Before drugs. Your orthosis. Okay, so you need to give various kind of orthosis depending on the problem, AFOs or push knee braces or above knee AFOs or whatever, depending on your problem. So you can consult your physiotherapist, you can discuss with them, you can discuss with your pediatric orthopedics, and then you can decide the best orthosis for your child. But that is very important again. So I think before drugs, you need to correct it mechanically if possible. Okay, so physio plus orthosis is very, very important in such kids, this spasticity. Then your drugs will come.
Okay, so Sagarika, what are the main principles behind physiotherapy you advise to your patients? So what do you like aim with the physiotherapy? Like you will who's going to advise him do some physiotherapy techniques and all. So how it's going to help and what are the main areas where you want to work with the child? He's 9-year-old. He's still scissoring. He has a gait which is like a crouch with the flexion at the hip, flexion at the knee, and plantar flexion. Plantar flexion, or it walks with the flat foot? Because you have
Plantar,
not mentioned about any contracture here.
uh, plantar foot.
Means there is an ankle contracture. Okay, so what are the main aims or methods you want to tell your patient that how is how you should be doing it?
Uh, Ma'am, both the knees are locked. We can advise to uh, keep the patient in such a position while sleeping that it can be matlab, abducted away from each other. We can advise to keep a pillow between legs and
Okay, so you should advise regarding them about muscle stretching as well as muscle strengthening. Okay, because these muscles are not properly used, they are weak, and once they are weak, they tend to become shortened and they develop contractures. Okay, so since he is 9 year old, I see that he must have already developed some contracture at the hip as well as knee because his gait is like that.
yes,
So our aim should be when we tell or when we explain about the importance or techniques of physiotherapy, we should always tell that these two aspects they have to do. Stretching for like muscle lengthening to prevent deformities, to prevent contractures, shortening, and strengthening is to increase the strength of the muscle. That could be active or that could be passive.
yes.
Okay, so these are the main aim for doing physiotherapy in this child. And rightly said, uh, as appropriate orthotic devices should be given to them to prevent as well as contractures, as well as to improve the posture of the child. Okay, and regarding my question regarding the management of spasticity, which are the spasticity conditions which has to manage by local measures, and where do you manage with them drug? When do you consider drug therapy would be more appropriate, or when you consider that focal measures will be more appropriate for these kids?
When patient is having difficulty in his routine activities.
No, madam is asking about which kind of CPs, hemiplegics, diplegics, quadriplegics, where you use drugs, where you use focal treatment means your botulinum toxin or some plasters or something. So in which conditions you use drugs and in which condition you will go for focal therapy.
Focal therapy can be in hemiplegic because only one side is affected. In
Good.
quadriplegic, both the upper and lower, all limbs are involved and spastic. So we can try drug better than local therapy.
Okay, so when you have a spasticity which is limited to a very particular area, then the focal therapies are more useful. So examples as you given that hemiplegic CP, if you have like involvement of particular muscle or particular joint, like you have a asymmetric involvement of one leg more as compared to the other, then usually the focal therapies are required. Focal therapy means like you can advise them splintings, you can advise them repeated castings or local botulinum toxin injection. But when you have more generalized, like in your patient, he has got drooling, diplegia, then the drugs would be helpful in managing such conditions. So, what are the drugs you can use?
Uh, Mostly we use baclofen as a muscle relaxant. We can use diazepam or midazolam, but it has a more chance of s- uh, sedation in the patient.
Okay, so again, you have several groups of drugs which can be used for spasticity. They act on different part of the neuroaxis which is involved in generation of spasticity. One group is like you have baclofen, which is overall muscle relaxant because of calcium channel inhibition. Another group of drugs which can be used are benzodiazepines. Diazepam, midazolam are not good options. You can use long-acting muscle relaxants like clonazepam in these conditions, but again, drooling may increase or sedation may be a side effect. Then you can use tizanidine that can be given orally, and then if you have additional dystonia or extrapyramidal feature, then trihexyphenidyl or tetrabenazine. These are the drugs you can use for management of uh, tone problems in these children. And then you can have like additional mm, baclofen pumps or intrathecal baclofen and rhizotomies for diplegia. Basically, they can be used uh, if those are available. Uh, to, okay. Uh, Now, just for the sake of discussion, can you enumerate the comorbid problems which needs addressing in children with cerebral palsy? So, like, you should enumerate all these problems and whenever you have any patient with cerebral palsy, they should be like 1 to 10, and always should be described. Uh,
In cerebral palsy patient, we can have problems such as language and social problem, behavioral problem in motor using motor component, and we can have comorbid conditions like contractures of muscles, and we can have repeated respiratory tract infection. We can complain of chronic constipation or uh, uh, incontinence of bowel and bladder. Uh, GERD problem in patient of cerebral palsy, regurgitation, and
Good, good. So you described many problems. Little more common problems, 2, 3.
multiple episodes of convulsion. We have
Good,
to.
good. Seizures. Yes, madam has asked in history also. Vision and hearing.
Yes, problems of vision and hearing, and difficulty in feeding, like drooling, and they can also have difficulty in sleep disturbances.
so agree. I think she has enumerated most of them, but you should always also ask about malnutrition. Very
Yes,
very common. then teething problems, malocclusions, caries, okay, and sleep, obviously, and contractures, deformities. So, a child with CP comes with all these problems, and host of problems are always there. And if you do not ask them, you tend to miss them. And we follow a dictum that in neurology, we don't just go by four areas or four domains of development. It is always six. So, along with gross, fine motor, speech and language, cognitive, adaptive, we always take history of vision and hearing. So, it is very, very important. I think you should make it a habit that in neurology cases, there are six domains of development which you always have to ask.
Yes.
You should never miss the vision and hearing issues in you. All are important, but should not be missed even in the history as well as in the examination.
So Sagrika, you have described all the problems. Almost everything is described. But if you just like go little methodically, then few are related to your neurological insult and few are medical problems. So I think if you see the definition of CP, there are 5 comorbidities. Okay. So one is your intellectual disability associated with your motor. That is one thing, cognitive problem. Second is your behavioral problem. Third is social communication problem. Fourth is your sensory, that means vision, hearing, everything. Fifth is epilepsy. And sixth is associated musculoskeletal problems.
Yes.
Your contractures and dislocations. In this case, also hip X-ray is very, very important.
Right.
At 9 years, you must get hip X-ray just to see the what is the situation of femur head. So I think these are the 6 problems which is core: cognition, behavior, your epilepsy, your sensory problems, and your musculoskeletal. Then you have some lots of medical problems like feeding issues, constipation, sleep issues, caries, malnutrition, nutrient deficiency, recurrent respiratory infection. Because of drooling, there is lots of excoriation of skin and all these things. Because of spasticity and because of seizuring, many times the perineal hygiene is affected and lots of skin issues are there. So these are all secondary. But your core, because of insult in your brain, these are the 5-6 core problems and 5-6 other medical conditions. So these all 10-12 conditions, as madam rightly told you, that in each CP patient, in your practice also and everywhere, it's not just for exam sake. In your all CP patient, just all these 12 things associated 5-6 problems and associated 5-6 medical problems. This should be in your mind. It's not just CP ma kahi na thai. That is our standard. Lots of things to be done in all these areas. Okay. So it requires very meticulous, very methodical approach. Otherwise, you'll miss many things. And these hip dislocations are missed a lot. Like what I see in our practice, nobody gives much attention on hips, and then they come with major problems. So always get an hip X-ray done yearly or 2 yearly in all your CPs, which is affecting predominantly both your lower limbs. Madam, you want to add something regarding comorbid or other associated problems?
No, I think it's very rightly said, Dr. Ritesh, because life of these children has to be comfortable, and for that, all these comorbid problems are usually much more problematic to them rather than underlying disease. So addressing these points itself makes a big change in their life. So it's always very important, and I ask my residents to you have the list and always go through this list of around 12 complications and in these patients. So they should be like enumerated and has to be asked. They should not never be missed in these children, because comorbid problems are usually the one that brings to patients to your clinic or your practice. Maybe epilepsy, maybe deformities, severe constipation, GR, sleep issues. These are the things which brings the baby to the clinic. So they has to be addressed and has to be asked. Okay, so now regarding assessment of a child with CP, now can you tell which scales you commonly use in your practice to quantify the problems or
We use GMFCS score, which
Okay.
is gross motor system scoring system, and another one, ma'am, we have for upper limb involvement, hand involvement, and which is velocity dependent. It is motor system scoring for the patient CP. They have stages.
Okay. Okay, so there are several scores which are available. GMFCS is one common, which is usually a functional score that how much disability is there. But several scores are there which can help you in addressing the problems. The core ones are related to the tone problems like Ashworth and Tardieu scale for tone problems. Then you can has MACS we use for upper limb functioning manual ability classification for functioning of hands, and we use scales for drooling also, like how significant is drooling and how you are going to manage the drooling. So some of these scales can be used in these children just to address the problems in a methodical way that at this stage you want medical therapy, and before that you want more of rehabilitation techniques or devices. So you should remember these scores just to assess the tone and functional status of the child. So some of these are commonly used in the clinic.
Just to add to Madam's comments, that this scoring is never boring. Okay, usually we think that these are all just time pass and all this, but this scoring will help you to prognosticate also. Like in GMFCS, you have 1 to 5. 1 is your normal gait, 5 is your bedridden child. Okay, so if you are seeing some CP at 7 year with GMFCS 5, then what hope you can give to that child? With whatever treatment you can do, you can just jump 1 or 2 GMFCs. You cannot jump from 5 to 1. Okay, so you can go from 5 to 4 maximum. Or if we do lots of efforts and everything, then maximum you can go up to like 3. But it is usually just 1 GMFCS you can change with whatever you do. So this you have some GMFCS 3, and you can tell them that we can go to GMFCS 2 or something. If they're at 4, you can tell them that we can go at 3. So this scoring is actually very much useful in your counseling and your strategy designing. So this CP you cannot manage alone. It is always a team. Like what in our center, what we do is we have a pediatric orthopedic surgeon, we have a pediatric physiotherapist, we have myself, we have pediatric colleague, we all four, we have a pediatric dentist. All these 5-6 people get together, we'll make a plan for the treatment. So to give the realistic expectation to the parents, you need this course. And you can speak common languages. Suppose I am not there, somebody else is taking care of the patient. So if you have the documentation of the score, then your counseling will not differ much between different individuals. So I think these are all chronic patients. They require care for years together. So you cannot just give rough answers. You can just lose answers to them, because that will change their mindset. So I think this scoring and documenting the score is very, very important in CP patients. I, in my practice, use GMFCS very routinely, and I think I'm getting like I'm very comfortable with using it, and uh, it is.
Okay, so Garika, last question from my side. How will you break the news, or how will you counsel the parents? He is 9 year old, but if you get like infant or 1 year old, 1.5 year old child, where you think the diagnosis, that what are your counseling strategy? How are you going to counsel the parents?
Uh, and we have to explain that whichever damage has happened, which is going to be there lifelong with the patient. We can help him to decrease his comorbidities and improve his daily routine, if at all we takes care of the patient as early as possible, and do not stop or uh, discontinue any treatment from where it is started, because it is going to be lifelong for the patient. And uh, and we can explain that for which reason the patient is having such complication and a group of disease. Patient is different from other same age group patient, and will have difficulty in the uh, economical and education life in future, and we have to prepare them for that, uh, to have a mindset that a patient is uh, delayed in development than other same age group patient.
Yeah, so I think you should explain the situation, and also do not focus on negative aspects. Always give them some hopes. What are the positive aspects of this kind of pathology is that usually these are non-progressive. First, you have to emphasize on that, like these are non-progressive
Non-
conditions. Okay, and second, the manifestations may change with time, but it's not like a progressive disease. This is the second point you should mention. And third, what all can be done to improve the functional status, that you have to tell them in a positive way. So if you are going to just focus on negative aspects, then I think the rehabilitation or the care child may require. Uh, Sometimes parents may feel that, like, now since they have told that nothing can be done, so that should not be your way to explain them. So always give them some hope, some positive aspects in which they can work on, and explain that these are non-progressive disorders. So always there is some things to work on the child. So, and then manifestations may change with little bit with age, and but the and then as Dr. Ritesh has said, you can use the GMFCS scoring and all these to counsel the parents about the
Progress.
prognosis in these cases. So counseling becomes very important, and you have to tell them uh, like what I explained them, the area which is non-damaged is still there, and lots of functioning can be achieved through repeated uh, maneuvers and therapies. So we have to work on those areas. So that will be more rewarding in case these cases. So I think these has to be tailor made, and every individual has a different way, but most of the time these are the ways you focus on positive aspects also.
As Madam rightly mentioned everything about counseling, so I think always use the positive things, like tell the capacity, beautiful capacity of the brain regarding, use the term plasticity also. You can tell them to read about it also. So brain has a lots of plasticity. So you just tell them that which are the area which is not damaged, can be trained in a better way if you do repeated exercise, repeated maneuvers, early interventions, all kinds of therapy, all kinds of stimulations. The importance of all this is to train the preserved brain. Okay, so tell them in positive way that this is all possible. Give them some success stories. tell them regarding your some previous patients, he's similar like you, and now at the age of 6 years, he's going to school with little difficulty or something like that. So always, because your first counseling is very, very important. When we get the patients as a neurologist, usually they come as a second or third step, and with lots of negativity in their mind. So I think first counseling and one thing which I tell to my friends, who is an older child, majority of CT, what we see in our practice is acquired. But in the hope or in the fear that second child will also get same problem, they will not go for second child. So tell them that this is an acquired problem. If it is acquired, you are sure. Tell them this is an acquired problem. This is an accident which has happened to your child. Go for second pregnancy. This will happen. So just not you are encouraged, but tell them because it is very important. For 5 points, always tell first is static disease, non-progressive injury. Second, manifestation will change with time. Third, lots of good areas, lots of like many diabetics, many hemiplegics are intellectually very good. They're as good as normal kids. So they're not associated with global delay always. They're not associated with typically what we call mental retardation or intellectual disability. Fourth thing is it will not be repeated in your second child. And fifth thing is about plasticity. So these are the very important counseling points which will give them lots of hope about their child, and they will work in a positive manner. I think we have covered almost history, examination, differential diagnosis, some investigations, management, counseling, drugs. Uh, Madam, do you think anything you just give some finishing comments?
Yeah, I think it was a well discussed case, but few points for Sagarika to you remember that I think it has to be first and foremost the history. You should always ascertain the degree of encephalopathy. Like if you have a really significant asphyxia, you can use some of these scores, Apgar's, pH, cord pH. If it is not there, then always ask about feeding, encephalopathy, tone problems, and seizures in the first 24 hours or 48 hours. They will give you an idea that there was a significant asphyxia was there or encephalopathy was there. If it is not there, then you should always think about other differential diagnosis. So first and foremost point is that history has to be regarding encephalopathy part. You should be very clear in the history. Now the second part is when we take a case of cerebral palsy, I think it's important to, in the history as well in examination, go for all the comorbid problems which we have learned right now. And so you should be looking into the history in examination as well as asking in the history. So these points should be in your mind. So always ask about vision, hearing, feeding, drooling, teeth, and all those problems which we have. Dr. Ritesh has very beautifully explained, and they are in the two domains they are there. And regarding third point, examination, I think head circumference, it has to be measured properly. And ideally, it is 3 measures, and you take average of the three because 1 mm or 2 mm variations can be there, but it has to be measured on the temples basically. Okay, as that is very very important. Again, in examination, you look for all the conditions, comorbid problem, tone, contractures, and functional impairments. Functional impairment you have not discussed, but all these has to be issued discussed, like what is the functional ability of the child, what all he can do by himself, and where all he is dependent on other activities. So that will help you in planning the care. Sometime just maybe problem will be there in using washrooms, squatting on its toilet seat. That could be a very big problem for the parents. Okay, So if you ask them what are the main problems do you feel in day-to-day activities, they will enumerate these are my problems we face with the child, and then you can make your plan according to addressing these problems. And regarding counseling, always focus on give some hopes and tell them about the positive aspects of the condition. And but parents should be told that you can work on these areas. This is going to help your child. And mostly I see that comorbid problems are the condition which bring the child to the clinic rather than CP per se. So please address these comorbid problems. They are very, very important concern for the parents. Sometimes sleep is so disturbed, so the parents may not be able to sleep. So mothers are usually they who keeps on staying awake throughout the night with the child. So I think you can help them with addressing these issues. So life of the child as well as the family would be easier if you address these issues. So I think these are the points where a child with CP will need help. So I think CP is one of the most difficult case to be presented because there are lots of issues this child has and lots of people required to rehab these kids. So otherwise
Whole
we will discuss.
there. Whole neurology is there in CP.
Right. So
So it is like definitely a difficult thing to discuss.
yeah,
And
right.
but you do it, Sagarika, very well done. Congratulations, you did very beautiful.
Yes. Thank you. Sagrika, can you stop screen share?
Yes.
Yeah. I thank both the experts. You covered all the aspects like A to Z, and even the counseling. And Ritesh sir has given two wonderful sentences. One is scoring is not boring. I like that. And another that's in Gujarati actually, ma'am. But like in the busy OPD of neurology, when we were not having neurology as a specialty, generally in the pediatric neurology OPD, the attitude was આમાં આગળ કંઈ ના થઈ શકે. So it's not possible to do anything now when the CP comes. So both the things that you should not speak them, give them some hope, and the scoring is required. These two were excellent. I really thank Renu ma'am for guiding us for this journey. The CP is really a difficult case, and to prepare it so nicely, Sagrika, it's a congratulations for you also. And Ritesh sir agreed to be on this platform even though he was traveling for the neurology conference. So we thank him also.
Thank you.
Yeah, Yogesh sir is there if sir wants to give some closing remarks. I think he is busy. So
No, thank you, madam.
Okay. Yes, sir.
I am listening, but doing the simultaneously some work also. So thank you very much, Dr. Renu madam and Dr. Ritesh Pai, for the nice conducting this session and accepting our invitation on the short notice. So thank you very much, Dr. Mehal madam and Dr. Prashant Taria also. And congratulations, Dr. Sagarika and mentor Archana madam. Thank you very much.
સાગરિકા અર્ચના મેડમ ને મારા પ્રણામ કહેજે, મારા પણ મેડમ હતા VF માં.
Yes.
Yeah. Okay.
એટલે
Thank you
તમને
all.
રાખેલા રીતેશભાઈ તમને ઇન્વાઇટ કરેલા. ઓકે, થેન્ક યુ મેડમ. રેણુ મેડમ, થેન્ક યુ.
Yeah. Thank you all. We can close the session now.
Yeah. Thank you so much.
So yeah, Nishita, you can close the session now.
Yes, ma'am.
And
Thank you so much.
Thank you, Nishita and
Clarinet for
Clarinet
providing
team.
the platform. Yeah.
Thank you.
Thank you so much, everyone.